Bismillahirrahmanirrahim. Assalamu alaikum. In this video, we are going to continue our discussion about peptic ulcer pharmacology. So now we are going to discuss about a very important factor responsible for causing peptic ulcer, and that is H. pylori. What is this H. pylori infection? So it happened in 1982 that two Australian scientists, Barry Marshall and Robin Warren, they observed in their patients that the peptic ulcer was caused by some kind of bacteria. Although at that time the scientists and doctors used to consider this concept ridiculous, that a bacteria could live in that acidic environment of the stomach and cause peptic ulcer. And so in 1982, actually they performed the culture of the H. pylori and they developed their hypothesis that the bacterial cause of peptic ulcer was a reality. At that time, the scientists and doctor used to believe that peptic ulcer was due to hurry, worry and curry. It means that it was a psychological and stress oriented disease, or it could be caused due to spicy foods. So Barry Marshall and Robin Warren, they failed to actually induce H. pylori in the animal models. So this led to such a situation that Marshall himself drank a broth containing the H. pylori culture. And eventually, within few days, he started to feel all the peptic ulcer symptoms. And when an endoscopy was performed, it showed active gastritis. So with this experiment, he was able to prove that H. pylori was a pathogen that was responsible for causing peptic ulcer. In 2005, Nobel Prize in Physiology for their marvelous work in H. pylori was awarded to Barry Marshall and Robin Warren as an honor for their discovery of the bacterium H. pylori and its role in gastritis and peptic ulcer disease. Well, H. pylori is a gram-negative bacteria and it colonizes the gastric mucosa, and especially it is present in the antrum region of the stomach and the first part of the duodenum. Now, actually H. pylori itself, it does not like HCl. So you can see in this figure 1, the H. pylori is trying to hide, or we can say run away from the HCl, and it actually usually is found in between the mucus and the epithelial layer. So it's stuck there. It burrows itself into the mucus layer to hide from the HCl. And now when it is in touch with the gastric epithelial cells, with time it starts producing some kind of proteins and it causes damage to the mucosa due to the release of different kind of proteases and molecules. Now if we talk about the diagnosis of H. pylori, the most common and non-invasive method for detecting the presence of H. pylori is urea breath test. So H. pylori has this specificity that it has a urease enzyme and it has the ability to convert urea into carbon dioxide and ammonia. So in this urea breath test procedure, the patients or subjects, they are actually given urea labeled with carbon 13. So this is an isotope labeled oral medication. So after the patient takes this urea labeled with 13C, what happens is that if H. pylori exists in this subject, the H. pylori converts this 13C urea into ammonia and 13 carbon dioxide. and this 13 carbon dioxide is exhaled out and then detected. Now, infection with H. pylori doesn't mean that the patient will suffer from peptic ulcer. A lot of surveys has seen that 50% of the patient do have H. pylori, but they don't have any sign and symptom related to peptic ulcer. And if we talk about its prevalence, it's highly prevalent in Pakistan, and the percentage is around 81%. So if H. pylori is present in 50% of the population, it's just going to cause peptic ulcer in 10% of them. So briefly talking about the major sign and symptoms of peptic ulcer, on top we have epigastric pain. So the major difference between gastric ulcer diagnosis, or we can say the sign and symptom, is that a patient of gastric ulcer will have pain when they have food. Why? Because when they take food, HCl is produced, and that HCl is going to irritate the ulcer. On the other hand, usually the pain of duodenal ulcer is localized, pinpoint, and patient usually feels relief when he has taken his meal, and pain usually occurs after 2 hours of taking a meal. And if we talk about the prognosis of the disease, duodenal ulcers, their prognosis is far better than gastric ulcers because mostly they lead to gastric cancers, and the treatment of duodenal ulcer is even more easier as compared to gastric ulcers. Now you have to keep in mind that for initial diagnosis, urea breath test is used, but after confirmation, then we have to do endoscopy to see the size. Usually the size of ulcer is in between 1 to 2 centimeter and not more than that. But if the ulcer is greater than that in size, we call such type of ulcers giant ulcers. One very important diagnostic method is the barium meal. When the patient takes this barium meal is shown as white in color, and as it moves along the GIT lining, if there is an ulcer, that ulcer will be well demarcated, and that demarcation or collection of the barium meal on that area of the ulcer is known as ulcer crater. You can see in this figure, we have one gastric ulcer, barium study of gastric ulcer, and duodenal ulcer in patient of peptic ulcer disease. So after H. pylori, we have NSAID, non-steroidal anti-inflammatory drugs, and aspirin that are also a cause of peptic ulcer. Those patients who take these drugs for a prolonged time are prone to develop peptic ulcers. In this figure, you can see the mechanism with which NSAID acts. NSAID actually, it blocks cyclooxygenase 1 and cyclooxygenase 2. Ultimately, NSAID are used to inhibit prostaglandin, that is also an inflammatory mediator. But what happens is that we have two types of pathways. One is COX-1, which is responsible for making those prostaglandin that have a cytoprotective action in the GIT that we have discussed, and it has the other prostaglandins that are involved in inflammatory process, COX-2. So as a result of taking NSAID, what happens is that the protective or defensive factor of the GIT becomes weak, and as a result this can lead to peptic ulcer. Because if prostaglandin secretions decreases, then ultimately what happens is that it was responsible for enhancing the blood flow, it was responsible for secreting the bicarbonate ion and enhancing the mucus secretion. So all of these defensive factor becomes weak, and ultimately what happens is that the aggressive factor cause mucosal injury.